Welcome back, everyone. Welcome back for the special Amgen session. This is a very, I think this is certainly an area of interest. Even though we don't see Behcet's disease all that often, certainly it is great to get a good insight into possibly a therapy for this condition that's often very challenging to treat. And I always love hearing Dr. Dutz speak. He's always right at the cutting edge of immunology and dermatology and rheumatology. So I'm always very, very interested in his talks. Dr. Dutz is a professor and head of the Department of Dermatology and Skin Science at the University of British Columbia. He's a senior scientist with the BC Children's Hospital Research Institute, where his research focuses on the skin immune system and the manipulation of this system to promote immune responses and induce tolerance. He is a rheumatologist and dermatologist with special clinical interest in the cutaneous manifestations of autoimmunity and rheumatic disease. He also works as a dermatological oncologist at the BC Cancer Agency, where his practice is restricted to malignant melanoma and skin lymphoma. Dr. Dutz, the floor is yours.
Okay, I hope you can all hear me. So I have the pleasure to talking to you today about Behcet disease and how it may be relevant to your practice. Here's my list of conflicts of interest. I don't really think they're relevant for the talk that we're going to go through today. So what I'm going to do first is give you a little bit of an overview of Behcet's disease and again, how it's relevant for dermatology. So Behcet's disease is chronic multisystem inflammation, which was initially recognized as variable vessel vasculitis, affecting both the veins and the arteries, and characterized by recurrent oral and genital aphthous ulcers. Now, it involves multiple other systems, but it was the association of the oral ulcers, genital ulcers, and eye inflammation that led to the recognition of this disorder by Hulusi Behcet in Turkey. So a classic hallmark of this disorder is really recurrent oral ulceration. So that can be either as minor ulcers, major aphthous type ulcers, or even herpetiform ulcers. These ulcers are certainly painful and occasionally they can scar. However, it is not only a cutaneous disease. As you can see, you can get ocular disease, and that is a cause of major morbidity in the Mediterranean countries. As a rheumatologist, I see patients with neurologic disease, with vascular disease, with joint disease, and also with gastrointestinal disease. However, most of these patients present initially with oral ulcers and then with oral and genital ulcers, as well as other skin lesions. Now, this is a disorder that is most frequent around the Mediterranean and around the so-called Silk Road. So that's an area that goes from the Mediterranean east towards Asia. In North America, the incidence of this disease is about 5 per 100,000, but it is likely under-recognized. Now, it turns out that the clinical story or appearance of these patients is somewhat different in the Silk Road population compared to the North American population. So in the Silk Road population, that is around the Mediterranean, it's more common in men than in women, whereas in North America and in Europe, it's women have the disorder more commonly. Pathergy is more predictive in the Mediterranean and Silk Road population than it is in the Caucasian population. There's a genetic background of HLA-B51, which predicts more severe disease and is seen more commonly in the Mediterranean population. In the Caucasian population, about 15% of patients are HLA-B51 positive. And in general, the disease tends to be more severe with more systemic disease, more GI involvement in the Mediterranean population than in the North American and European population, where mucosal and skin involvement are really the most common features. Now, the clinical manifestations are a result of a genetic predisposition and potentially several environmental factors, such as herpes infections, bacterial infections, possibly environment such as pollution, which leads to an activation of the immune response. And studies in Europe have shown that the immune activation is multifactorial. So you get a number of cytokines that are upregulated in the T cells in the lesions, and those include IL-2, IL-6, IL-17, IL-23, TNF-alpha, and interferon gamma. And this leads to the clinical manifestations of Behcet's disease. Now, the problem in terms of diagnosis is that these patients often present with oral ulcers, and oral ulcers themselves are not very specific. They can be seen in multiple skin diseases, such as Stevens-Johnson syndrome, bullous disorders, lichen planus. They can be seen as a consequence of infections, such as herpes simplex virus. They can be seen in autoinflammatory conditions, such as FAPA or hyperimmunoglobulinemia D. They can also be seen as a result of drug toxicities, such as methotrexate. So there are many pathways to oral ulcers, and these patients with recurrent severe oral ulcers will often present to the emergency department or to oral medicine specialists, and the diagnosis may not be appropriately made right away. So one of the ways that we classify Behcet's is using classification criteria. These were initially developed in 1990, and the recurrent oral ulcers is really at the basis of this. In addition to the ulcers, patients need to have also other features such as genital ulceration, eye inflammation, skin lesions such as erythema nodosum, folliculitis, pseudofolliculitis, acneiform lesions, and or a positive pathergy test. This is a classification system that is used to enter people into studies, such as what we will be seeing in a few minutes. There have been some modifications made to this classification scheme. The most recent modification was in 2006, or about 14 years ago. And the addition here was the recognition of vascular lesions and the importance of vascular lesions in this disorder. Pathergy is characteristic of this disorder, but as I mentioned earlier, more common in the Mediterranean population than in the European or North American population. It's characteristic, but not necessarily diagnostic, because it can also be seen in other neutrophilic disorders, such as pyoderma gangrenosum. The standard technique is to use a 20-gauge needle to prick the skin and to re-examine it in 24 hours. So how burdensome is Behcet's disease? And specifically, the oral manifestations that are most common in the patients that we would see in North America. So it turns out that these oral ulcers in Behcet's disease tend to be more persistent and also more painful than those of recurrent aphthous stomatitis. And this results in difficulties eating, speaking, and in difficulties maintaining oral hygiene in people that have this. In addition, one can get severe internal organ involvement, but this is really more common in the patients around the Mediterranean, where young males tend to be those that have the worst disease, and the standardized mortality ratio can be as high as 10 in those young males. And why? Because these males also get concomitant vascular disease and neurologic involvement. In the patients that I've looked after, GI involvement and eye involvement has been most common. So how do we manage Behcet's disease? It's a disease that can affect multiple organs, but most commonly the ones we see are those that get the recurrent oral and genital ulcers. And for that management, I have traditionally used colchicine, topical sulcrafate, and if that doesn't work, moved on to other agents. In terms of patients with GI disease, we've used TNF inhibitor agents in collaboration with gastroenterologists. Patients with significant joint disease, I've used azathioprine. And for the management of eye disease, in conjunction with ophthalmologists, we've placed patients on cyclosporin as well as TNF inhibitors. So there are many different areas of involvement, but really the most common one in patients in North America are the oral lesions, the genital lesions, and the skin lesions, so the mucocutaneous lesions. So these are the ones that are relevant for a dermatologist. Once a diagnosis has been made, the follow-up of these patients is really multidisciplinary, and you have to involve the gastroenterologist if there are GI symptoms. You have to involve the rheumatologist in your case if there are joint symptoms or vascular symptoms. So these patients can also have an increased rate of thrombosis if they have active vascular inflammation, and that is usually treated with active anti-inflammatories rather than anticoagulation. Now, EULAR, the European League Against Rheumatism, has come up with treatment recommendations for mucocutaneous involvement. And as you can see, if there's predominantly oral ulcers, the standard treatments are topical corticosteroids. I tend to use clobetasol, and I instruct patients to apply a gauze to the lesion first to dry it, then apply the clobetasol to a piece of gauze and hold it to the lesions. This is best done at night before going to sleep, because that is the time when normally you make less saliva, and therefore the treatment is more effective. If that doesn't work, I move on to sulcrafate, and if that doesn't work, on to colchicine. And I use a similar treatment paradigm, essentially, for the treatment of genital disease. If that doesn't work, we then look at other options, such as azathioprine. I have not used thalidomide. I've not used interferon alpha. I have used TNF alpha antagonists, and I have used Apremilast. Papulopustular lesions, I usually treat with topical clindamycin in an alcohol base. It's important for you to know that even though we have had colchicine for many years and studies have been done to look at this, the studies have not all been unequivocal in showing benefit of colchicine. So studies have been done using relatively high doses of colchicine, over 0.6 milligrams per day, which is what we normally use. And only 1 out of 3 studies has shown a statistically significant benefit. So in summary, Behcet's is a chronic multi-system disorder. Oral ulcers are the hallmark of the disease. This can make the diagnosis complicated because there's so many other causes of oral ulcers. The manifestations of Behcet's disease can have significant psychological impact because of the recurrent pain and difficulty in speaking and eating, which leads to impaired quality of life. The management should be tapered to the individual needs of the patient, and I've gone over some of my experience in that regard. Now, what about Apremilast in Behcet's disease? What evidence do we have that we can use this drug, and why was this drug studied for use in Behcet's disease? Well, Apremilast, as you well know, is a phosphodiesterase 4 inhibitor, which prevents degradation of cyclic AMP, and it decreases, therefore, the production of many inflammatory cytokines, including TNF-alpha, IL-2, IL-12, IL-17, and interferon gamma, all of which I told you have sort of been implicated in the inflammation that we see in Behcet's disease. And so this actually came out of an investigator-initiated study that asked the question, could we use this drug, which influences many cytokines, to improve the health of patients with Behcet's? So that study was published in the New England Journal now a number of years ago and was completed in 2012. It was a phase 2 study, and it actually showed that you could decrease oral ulceration in patients with Behcet's disease using Apremilast. What has been published more recently, now approximately 1 year ago, is the RELIEF study, which is a phase 3 study looking at Apremilast compared to placebo in the treatment of Behcet's disease. So this study was carried out in the Mediterranean. It also included patients from Europe, it included patients from Japan, and it included patients from North America. The key inclusion criteria were men or women over 18 years that met the criteria for the classification of Behcet's syndrome, and these were the 1990 criteria, and they had to have active oral ulcers at least 3 times in the previous year, despite the use of at least one non-biologic medication. So they could have been on colchicine and it didn't work, for example. Now, importantly, patients with severe systemic disease, that is a history of CNS disease or active vascular disease, were excluded from the study. In addition, patients with severe eye disease, that is severe uveitis, were also excluded. Only patients with mild uveitis that could be treated with topicals were allowed into the study. Previous use of a biologic agent for oral ulcers was an exclusion. So those that had been treated with TNF-alpha inhibitors were not entered into the study. And obviously, other complicating disorders would exclude you from the study. So in this study, approximately 100 patients in each of 2 arms was either entered into a placebo group or an Apremilast group for 12 weeks. And this was double-blind, placebo-controlled. And the primary endpoint was the area under the curve for the number of oral ulcers. And I'll talk about that just a little more in a minute or two. There was then, after that first double-blind phase and 12-week endpoint, there was an active treatment phase that went on for another 52 weeks. And then patients were then followed after treatment was discontinued for another 4 weeks. I should mention that during the first week, just as is used in psoriasis, there was a dose titration that was occurred, and patients that were on in the study were not allowed to use colchicine, were not allowed to use other immunosuppressants, and even topical corticosteroids. So the primary endpoint was the area under the curve for the total number of oral ulcers. So this is definitely a dermatologic endpoint. The measure reflects the number of ulcers over time and was used because of the relapsing remitting nature of Behcet syndrome. The number of ulcers that was counted for analysis of primary endpoint included current and recurrent ulcers at each time point. And therefore, a single ulcer could be recounted if it was persistent. And it gave an indication of persistence of ulcers. This is the classic consort diagram of this study, where 282 patients were assessed and 207 underwent randomization 1-to-1. 103 were assigned to receive placebo, and 104 were assigned to receive Apremilast. You can see that the discontinuation rates were approximately 10 to 20%, and it was higher in the placebo group during the 12 weeks than the Apremilast group. There was then this extension phase to 52 weeks and the follow-up phase. So what were these patients like? So the average age was about 40 years old. There was a slight preponderance of women in this study, and there was about equal proportion of patients from Asia and Europe, and about 10 to 15% of patients were from North America. Many of these patients had Behcet's disease for an average 7 years, with a significant number of oral ulcers, significant oral ulcer pain. Most of these patients had been tried on a number of different agents, including colchicine, oral steroids, and other immunosuppressive agents. So the primary endpoint was the area under the curve at 12 weeks. And you can see that there was a significant difference between those treated with Apremilast versus those that were placed on placebo. And this difference occurred rapidly. By 2 weeks, there was a significant difference. And this significant difference favoring Apremilast was essentially maintained for 12 weeks. In addition, there was a significant change in pain in those patients. So not only did they have a significant decrease in the number and persistence of oral ulcers as determined by the area under the curve, but there was a decrease in pain by 2 weeks that then was persistent up to 12 weeks. Now, there was a whole number of sub-analyses that were done to see if there were other factors that could mitigate response to treatment. And I can share with you that those that responded best according to this analysis, as you see, had disease duration under 6 years. There was slightly less good response in those that were over 10 years, but the confidence intervals get wider because the numbers are definitely smaller. The same thing happens with number of ulcers. So there was a good response to those that had 2 to 5 ulcers as a baseline oral count. Those that had over 10 ulcers had a slightly wider confidence interval because there were only very few patients. Those that had previously been treated with colchicine or not made no difference. Prior oral corticosteroids or not also did not make any significant difference. In terms of complete response of oral ulcers, that is complete resolution and no recurrence at 12 weeks, again, significant difference favoring Apremilast, and achieving complete resolution over an extended period, again, favored Apremilast. Now, as I said, the study was extended, and the extension of the study was published up to week 28 in the New England Journal article published about a year ago. There was then the people that were in the placebo group were crossed over to treatment, and you can see those that were in the placebo group, once they crossed over to treatment and were in the active treatment phase, had a very significant decrease in the mean number of oral ulcers. They also had a significant decrease in pain related to the oral ulceration. Now, if we look at adverse events, the adverse events here are described as number of patients and adverse events averaged over the amount of time patients were on drug, so EAIR. And some of the differences that you can see are what we would expect. That is, there's an increase in diarrhea, some slight increase in nausea and headache, but these events are loaded to the front end of the trial. And if patients, when they stay on the drug, those side effects decrease. Serious adverse events were few. There were a number of patients that had to stop drug because of migraine and other things. But there was really only worsening of the ulcers and such in one patient, and no deaths or other serious events were reported. So the takeaways are that there was a significant decrease in oral ulcers. 53% of patients assigned to the Apremilast group were free of oral ulcers at week 12. The improvements were observed in disease activity as well as patient-related outcomes. They were consistent across many of the subgroups, and the number of oral ulcers in decrease and pain was maintained through week 28. So now, in the last few minutes, I'd like to share the extension study results. This has not been published, but it was presented last year at EULAR while we were at the World Congress. And so you can see same consort diagram. It's the same study, just with continued analysis. And you can see that those patients who were then placed on treatment and followed for up to 1 year maintained an excellent response. Importantly, when the drug was stopped after 1 year, the number of ulcers started creeping up again. So it didn't cure the disorder, it just controlled the symptomatology. If you look at change in pain, again, the pain decreased, it stayed low and persistently stayed low until the drug was stopped when the symptoms recurred. In terms of complete resolution, there was it stayed around 50 to 60% until the drug was stopped after 1 year, when then response was lost. Here's another way of looking at treatment emergent adverse events. I'll draw your attention to over one treatment emergent adverse event leading to discontinuation. In the placebo-controlled period, that is the first 12 weeks, there were more discontinuations and dropouts actually in the placebo arm than in the Apremilast arm. And then when we go over the remainder of the study, you can see that there were less than 1 in 10 patients that discontinued the study during that 1 year time period. So in summary, this study shows that Apremilast 30 milligrams twice daily demonstrated significant benefit in terms of the domain of oral ulcers, which is a cardinal manifestation of Behcet syndrome and relevant for dermatology, as long as we can make the diagnosis. Over the 12-week randomized period, patients receiving Apremilast experienced improvements in the number and pain of oral ulcers, as well as overall disease activity measures, which I didn't go over in detail with you. There was a 50% reduction in the mean number of oral ulcers starting at week 1 and continued to week 12. And about 50% had complete resolution of oral ulcers by week 12. This was then maintained, and patients that were maintained on drug maintained response for up to 1 year's time. When the drug was then withdrawn, symptoms started to recur. So I'll refer you to this one article by Hatemi G, which is an update of the recommendations, the EULAR recommendations for the management of Behcet syndrome, and where the management tree that I pointed out for the oral ulcers is described. They also indicate in that paper the management for the other manifestations of Behcet's syndrome that I've talked a little bit about, but I didn't want to focus too much time. So I've finished my time period. I'm happy to entertain any questions. Thank you very much. I hear one hand clapping. That's great. Thanks.
Thanks very much, Dr. Dutz. That was excellent. Unfortunately, we don't have any time for any. There weren't any questions virtually that came in. Just a brief question though. Like, do you find that this is your kind of one of your go-to agents for Behcet's disease when they failed colchicine, or do you sometimes start them on the medication prior to colchicine?
Well, in terms of access, still my practice is to put patients on colchicine first. But I sort of echo the results that I presented in the studies on colchicine. I don't find colchicine wonderfully effective, and so I usually combine that with topicals such as the sulcrophate and the steroids that I pointed out to you. And then next in that treatment ladder now is Apremilast, and I've had some success with that. Now there is something in the chat. I don't know what is there. Oh, just the timing. Good.
Yeah, it's all good. Thank you, Dr. Dutz, for your outstanding presentation. I know I certainly learned some very good pearls on Behcet's disease, and I'm going to be looking very hard for it in my patients now that there's potentially some very good therapies. So thank you, Dr. Dutz, and we'll move on to the next session.
Very good.
Thanks again,
Bye now.
Dr. Dutz. Thanks to Amgen for putting on that open session.